the New York State Office of Mental Health on Reimagining Children's Services. We have a number of people that have registered to attend. I think we're probably going to wait one more minute before we get started. Welcome again to everybody who is attending the Community Technical Assistance Center of New York alongside of the New York State Office of Mental Health first webinar in our webinar series on Reimagining Children's Services. Before we get started, I just wanted to go through a couple things to keep in mind specific to the webinar system, especially if this is the first time you're on a webinar with us. Currently, we have a number of people that have registered to attend this webinar. Everybody will be muted during the entire webinar. However, if you have questions or comments for the presenters, there's a chat box on the right-hand side. If for some reason you do not see that chat box, there should be a chat button at the top that will pop up the chat box on that right-hand side. You can submit your questions by typing in the blank space, clicking on the drop-down, send to all panelists, and then hit send so that way the presenters can see your questions and comments. If you're having technical issues, you can send a chat directly to the host in the drop-down. There's a host option, or you can email alcantara@nyu.edu with any specific technical issues in accessing the webinar, listening to the audio, or anything else specific to that. As a reminder, this webinar will be recorded and it will be posted on the ctechny.com website in the next couple of days. We expect to have a number of questions coming in. We'll do our best to answer as many of the questions as we can. However, we know that there's going to be some questions that then we'll be able to post on the website and have the Q&A posted alongside the webinar recording. And again, that website address is ctechny.com, and it probably will be a couple days before it's posted. It's not currently posted right now. Thank you, everybody, again, for attending today's webinar. Dr. Mary Makeda, one of the directors of the Community Technical Assistance Center, will start us off and then introduce our presenters for today, Donna Bradbury from the New York State Office of Mental Health. Thank you, Mary.
Make sure you can hear me okay?
Yes, we can hear you.
Fantastic. So good afternoon, everyone, and thank you for joining us for Reimagining Children's Mental Health Services Part 1. So this is the first of a multi-part series, and it's my privilege to introduce our speaker for today, Donna Bradbury. Donna is the Associate Commissioner in the Division of Integrated Community Services for Children and Families. And I think that what I'm so grateful for, Donna, that your kind of commitment to children and their families, your leadership as we undergo significant transformation in New York State, you're seeing opportunities to support the hardworking provider organizations, to support the committed families, to do the right thing by young people. And then also, as we undergo significant changes in our state, you look for opportunities to consistently do things better and to support a vibrant public system. So I'm incredibly grateful for your leadership. I want to tell the almost over 700 people that have registered for this webinar that this is a series that was really inspired by Donna to be sure that we try to offer as much information to those that care about child and family mental health services in this state in advance of changes, and I really appreciate the support that you have given to CTAC to try to provide additional resources as well. So Donna, I'm really looking forward to hearing your comments. I know the rest of the folks that have signed on there's hundreds of people that are really interested in you setting a high quality, important agenda for children's services. So with that, thank you so much for talking with us today, and I, along with all of us on the phone, are really interested in what you have to say.
Thank you so much, Mary. That was a lovely introduction, and I feel rather humbled by it, but thank you very much. So welcome, everybody, and thank you for joining us on this November afternoon, on a Friday afternoon, nonetheless. Today I'm going to walk you through a set of slides that's going to cover quite a bit of ground. And as we said at the beginning, we do hope to have some time at the end to take your questions. But we're going to talk a little bit about why this is so important, why are we all gathered here today, why are there so many people registered for this webinar, why is this so important, what's the current state of affairs, what are some of the forces of change that are at play currently, and then really we want to talk with you about how can we work together to reimagine children's services. And then we've got CTAC to help us with that, and I'm so very grateful for the lots of really smart people at CTAC that are really committed to helping providers through this massive amount of change that's coming at us. So let's get started. So let's talk a little bit about social and emotional challenges of kids and why it's so important to meet kids' needs. Social and emotional challenges among children and youth create a significant burden for them and for their families, as well as for the people who serve them. These challenges impact kids' health, their well-being, and they derail their development. Half of all lifetime cases of mental disorders begin by the age of 14. Despite effective treatments, there are long delays, sometimes as much as decades, between the first onset of symptoms and when people seek and actually receive treatment. An untreated mental illness can lead to more severe symptoms and the development of co-occurring mental illnesses. When children with untreated mental disorders become adults, they use more health care services and incur higher health care costs than other adults. Left untreated, childhood disorders are likely to persist and lead down a downward spiral of school failure, limited employment opportunities, and poverty in adulthood. No other illnesses harm so many children so significantly. Despite all the need, mental health costs for children are often hidden because many of these costs are not actually accrued in mental health settings. They show up in educational settings, juvenile justice settings, and physical health care settings, such as emergency rooms. According to a National Institute of Mental Health funded study, an alarming 65% of boys and 75% of girls in juvenile detention facilities have at least one mental illness. We're incarcerating youth with mental illnesses, some as young as 8 years old, rather than identifying their illnesses early and intervening with appropriate treatment and supports. So these are some sobering statistics that many of you are already familiar with. This information is worth sharing with your colleagues and other child-serving systems. I presented to the New York State Association of School Psychologists this morning, and they were furiously taking notes on this slide, which was kind of interesting to me. On a regular basis, they deal with children with emotional disturbance, of course, yet they weren't familiar with these general statistics, particularly the impact on graduation rates. So I think it's really important that we make sure that we ourselves are familiar with these facts and that we share this information with other child-serving folks. We can talk a little bit specifically about the impact on education. So about half of students, about 50% of students with mental illness age 14 or older drop out of high school. It's the highest dropout rate of any disability group. So we really have to pay attention to this. So I blatantly stole this slide from Jane Quinn. Jane works for the Children's Aid Society, and she's the director of the National Center for Community Schools. And I hope some of you have seen her presentation or know her. She's a big, big proponent of community schools because she knows that kids come to school with lots of burdens. And this little cartoon does a good job of portraying that. And while this cartoon obviously focuses on the school environment, this concept of children carrying many burdens, of course, extends to all environments, right, including our own specialty mental health settings. It effectively reframes problematic behavior and reminds us to ask, what happened to you, rather than what's wrong with you. And let us not forget the profound effects of poverty on the children that we treat. Children in the poorest households are 3 times more likely to have a mental illness than children in the best-off households. Poverty and social disadvantage are most strongly associated with deficits in children's cognitive skills and educational achievements. Conduct disorder, for example, is 3 to 4 times more common in children who live in socioeconomically deprived families with low income or who live in a poor neighborhood. It is likely that poverty imposes stress on caregivers and that this stress inhibits family processes of informal social control, which in turn can increase the risks of harsh or simply ineffective parenting, and also can reduce parents' emotional availability to their children. The link between adverse experiences and childhood disorder is complex and involves the reciprocal effects from children, as they are not just the passive recipients of experience. There's a growing body of research relating to poverty and health, indicating that low income combined with disruptive demographic factors and poor external support generate the stress and life crises that put children at risk and may precipitate psychiatric disorders in childhood. I hope many of you, if not all of you, are familiar with the ACE study. If you are not, please follow the link and read up on it and spread the word. I spoke with someone just this morning from an Albany-based residential program who said that her program administers an ACEs questionnaire not only to the youth that they serve, but also to their staff. This action shows some wonderful insight into the relevance of trauma and the importance of us as providers of service to understand and address the effects of trauma. And this is, if you go to the ACE study website, you'll see this visual. It's a nice depiction of how early adverse childhood experiences compound over time, over someone's lifespan. And you'll see how these experiences can lead to social and emotional cognitive impairment, which then makes the adoption of health risk behaviors more likely and leads to disease and disability and ultimately early death. The overwhelming majority of children with mental illnesses fail to be identified. They lack access to treatment, and they needlessly struggle throughout their lives. Mostly due to the effects of stigma, millions of young people in this country are left behind or go without appropriate, necessary care. But we know that through appropriate identification, evaluation, and treatment, children and adolescents with mental illnesses can embrace the hope of recovery. They can achieve success in school, in work, and in family life. But it really takes us all working together to get to that point. So let's do a little bit about what the current state of affairs is now and what some of these changes that we've been alluding to are. So I like this visual because it reminds me that, you know, about 3 years ago when we first really started talking, at least on the children's side, about managed care transition, there was a lot of anxiety about it. And really all we were seeing was the change or potential loss. But as we've proceeded with our planning, we've really come to a point in time where we can see the opportunity that's inherent in the change. And it's very hopeful opportunity. There's a lot that we can look forward to. But what exactly are, when we say healthcare reform and we're talking about the Medicaid redesign, there's lots of things that we're talking about, right? We're talking about the Affordable Care Act, health homes, the exchanges, there's parity, mental health parity in terms of behavioral health coverage from commercial providers, and there's DSRIP too, and there's the Medicaid redesign. So we're gonna focus today mostly on the Medicaid redesign, but I do want to talk a little bit about the triple aim because it's a phrase that people hear about and people refer to it, but I want to go into it a little bit with you. So the triple aim refers to 3 goals at once: better care for individuals, and that's on really 6 dimensions that the Institute of Medicine put forth. And those 6 dimensions are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equality. The second aim is better health for populations in relation to the upstream causes of ill health, such as poor nutrition, physical inactivity, substance abuse, and poor behavioral choices, violence, and economic disparities. And then finally, reducing per capita costs by eliminating waste. It is worth noting that a guy by the name of Don Berwick, who was the administrator of the Centers for Medicaid and Medicare Services, or otherwise known as CMS at the time, he created that concept of the triple aim, and he specified that the third item, reducing costs, means that costs will be reduced, quote, not by withholding from us or our neighbors any care that helps them, specifically not by harming a hair on any patient's head, which I think is an interesting just a note about that there's a very clear intent here that in reducing costs, we're very clear that we're not going to remove any benefit that people need, that we're not going to do any harm. Berwick also said that rather than waiting for problems to manifest, actions should be taken to prevent them. That means addressing the causes of illness where they lie in communities by looking at daily habits, social supports, and everyday choices. In other words, community-based prevention is a good idea. Berwick also said that America is, quote, seriously underinvested in using what is known about preventing illnesses such as heart disease, asthma, and depression. Prevention, if we get serious about it, he said, is a big, big bargain. So, will this opportunity really manifest in actual results? None of this will be easy, Berwick admitted. All of us will have to change the way we do business, and there's plenty of work ahead. So that's a little bit what we're going to talk about today is what do we need to do differently, what kind of work is there to do. So, gosh, 3 years ago, more than 3 years ago now, there was a Medicaid redesign devoted to behavioral health. And it didn't take long for that group to say, you know, we need a special group just devoted to Medicaid redesign for children, because the needs of children and families are so dramatically different than the needs of adults that have behavioral health concerns. So the Kids MRP has been meeting for a long time now, and there's been a group of state leaders that has been working on creating the KIDS model. And the Kids MRP operates under the same guiding principles of the general principles of redesign that the adult group does, things like we need person-centered care management, we need to protect continuity of care, we need to tie payments to outcomes, et cetera, et cetera. So those general principles hold in the kids design just as much as they do in the adult design. But we're going to get into some specifics that are different for kids. And the first one here on this slide, you'll see that the implementation for the kids transition to Medicaid managed care is scheduled for January 1 of 2016. So I like this phrase, children and their families receive the right services at the right time in the right amount. Many of you will probably remember that's an old catchphrase from the Children's Plan that was quite a while ago now, back in 2008 when we issued that policy document. But this has been our mantra in the Medicaid redesign for kids for about the last year or so, because I think that this really captures a lot of what the essence is of what we're trying to get at with the benefit package and the design in general. We know that research shows that early identification and early intervention can minimize the long-term disability of mental disorders. Mental illnesses in children and adolescents are very real and can be effectively treated, especially when identified and treated early. And I want to accentuate that when I say early, I mean early in the relative sense. I'm not necessarily talking about little kids. It could be little kids, but we're talking about just catching things earlier in general. Research has yielded important advances in the development of effective treatment for children and adolescents living with mental illness. Early identification and treatment prevents the loss of critical developmental years that cannot be recovered and helps youth avoid years of unnecessary suffering. Early and effective mental health treatment can prevent a significant proportion of delinquent and violent youth from future violence and crime, and it also enables children and adolescents to succeed in school, to develop socially, and to fully experience the developmental opportunities of childhood. So I want to spend a few minutes talking about quality, because any real meaningful discussion on transforming healthcare includes quality improvement as a necessary feature. Indeed, the purpose of change and the reasoning behind decision-making is to improve quality. So if you remember a few slides back, I talked about this guy, Don Berwick, right? So he's the guy who came up with the triple aim concept, and he was the past president and the CEO of the Institute for Healthcare Improvement, and he was also at one point the administrator for the Centers of Medicare and Medicaid. So Don Berwick called this phrase his central law of improvement. Every system is perfectly designed to achieve exactly the results it gets. So, second law of quality improvement, to change the blank, you must change the blank. So let's see. To change the results, you must change the system. So all improvement is change. So hopefully by the end of today's webinar, you'll start to get some ideas about what are some of the highly effective and valued activities that you should keep doing, what you might want to stop doing, and what are some new activities that you should start doing. So we're going to pause a little minute, make sure you guys are paying attention, and we're going to do a little poll. So the question is, to improve quality, how important is it to create significant change in our mental health system? Is it very important, somewhat important, not important, or you're not sure?
Great. So there's a poll that pops up on your right-hand side of your screen. Just take a second to answer, and then in a couple seconds we'll close the poll, and then we can see some of the results. So to improve quality, how important is it to create significant change in our mental health system? Do you feel it's very important, somewhat important, not important, or not sure? Great. So Amanda, once we have enough responses, feel free to close that out and we can see the results. So they should pop up shortly. Sometimes there's a little bit of a delay.
Okay.
Great.
All right. So it looks like, if I'm looking at this correct, it looks like most people say it's very important to create significant change in our mental health system. All right. Thank you very much for that. Only a few of you aren't paying attention. That's good. Okay. All right. So, what are the OMH priorities for enhancing children's mental health services? So, let me talk a little bit about sort of the overarching goals of the Medicaid transformation. So, we're looking for more children to receive ideally screening and services generally earlier, including prevention and mental health promotion. We're looking to provide a step-down of a set of services for children discharged from higher-end services like inpatient, RTF, home and community-based waiver. We're hoping to provide a richer array of services to prevent escalation into higher levels of care. We hope to infuse system of care values into the design, values like services being family-driven, strength-based, individualized, and system-focused. And we're hoping to have better coordinated care, both within and across systems. So this is also something I borrowed out of the Children's Plan. It might look familiar to some of you who studied that. So this is just a sort of a visual representation for applying a social and emotional development sort of model on kids' services. So it's a little bit hard to read, but on the bottom here, it's about strengthening all children, right? Not just the ones that are identified, but all kids using youth development, applying protective factors. So this is the base of the triangle here. And then as you move up to the more narrower parts, you're talking about intervening. And as we've said before, intervening earlier, before kids are off track developmentally. And then at the peak, these are the most vulnerable kids, right? And making sure that they have the intensive services that they need to succeed. So keep this sort of a triangle or pyramid shape in mind as we go forward, because we're going to see it again in a little bit or something similar to this. So we'll talk a little bit about the themes that originated from the Children's MRT a while ago now, that the state team that's been doing work on the design has kept in mind, and we've built upon these themes. So again, intervening early, just been talking about that. We're looking for accountability for outcomes. And you'll see that we say even across all payers, not just restricted to Medicaid, but across all payers. We're looking for solutions that are that address the unique needs of children and their families. There's an acknowledgement here that the children's behavioral health system has been chronically underfunded. We felt that it's important to put that issue on the table and acknowledge it. And that children in other public or private health plans should have access to a reasonable range of the behavioral health services. So hopefully all of you, or at least many of you, have seen this image before, and because it feels like myself and my colleagues, we've been going all over the state showing people this slide. So hopefully you've seen it. This is the visual that represents the Kids managed care model as we've proposed it. Before I get into talking about the model, I do want to acknowledge that this project has included an unprecedented level of cross-agency collaboration and represents true joint planning. So when I present this model, it's not the Office of Mental Health model. It's the result of a lot of planning and collaboration between OMH, OASS, OCFS, and DOH. So the Department of Health, the Office of Children and Family Services, the Office for Alcoholism and Substance Abuse Treatment, and the Office of Mental Health. And it's been a lot of work by a lot of committed individuals to get to this point where we are. So New York's vision for the Children's System of Care integrates physical and behavioral health services within mainstream Medicaid managed care plans. On January 1, 2016, services that were previously carved out of managed care and paid on a fee-for-service basis will be included in the Medicaid managed care benefit available to children. And I do want to just point out, if you've been following the adult managed care work, you've been hearing them talk about HART, Health and Recovery Plans, which is a sort of a special needs plan. And with the kids design, we decided early on that a special needs plan or a HARP was not appropriate for children, that it wasn't a good fit. And that's primarily because kids' functioning is rather fluid and changeable, and we didn't think it made sense to move kids into a special plan if they're currently experiencing very intense needs, only to sort of have to move them out later when their needs lessen. So this box on the left portrays that this is a mainstream plan, so kids are going to get all of their physical and behavioral health care benefits through the mainstream plan. So consistent with the Medicaid redesign team's care management for all goal, every child that receives Medicaid will be enrolled in a high-quality, fully integrated care management program. That's this light blue box on the bottom. Care management will be provided by a range of care management models, including managed care plans, patient-centered medical homes, and health homes. Children with the highest levels of special needs who meet the criteria will be enrolled in health homes. In an effort to best integrate all care and services, plans will be required to contract with behavioral health, foster care agencies, and specific community-based providers, as well as pediatric health care and specialty health care providers that are already in their network. And this is the blue circles up here. These are those entities, those providers that the MCOs, the managed care organizations, will need to contract with. So children and their families, as you know, are involved in a variety of systems, and in order to ensure that all of that care is coordinated, plans will be required to develop and maintain working relationships with school districts, non-Medicaid funded community services and supports, regional planning consortiums, and local government. So that's the red circles on the bottom here. So we're going to expect the MCOs to develop some working relationships with those entities, even though they're not in a contractual relationship with them. So we also plan to align and transition the existing 1915C waiver services into one array of home and community-based services available for children meeting the level of need or level of care criteria, which I'm going to talk about more later. So this includes all the existing children's waivers. So you guys know that OMH operates a waiver for kids with serious emotional disturbance. OCFS also operates waivers for children in foster care. And DOH, Department of Health, operates something called Care at Home waiver, which is for kids that are medically fragile. The behavioral health, fee-for-service, Medicaid services, and the new proposed day plan services are represented in box 2 here, and we'll be talking more about that in a minute. And so let's move on. So all the existing Medicaid services will transition into managed care. And we've got a number of proposed new state plan services. So I'm not going to go into too much depth on these, except to say that there are a number of these services that are already offered in parts of the state or throughout the state. And for example, family peer support services are actually Medicaid funded through our home and community-based waiver. But otherwise, these services, the services that are available are not Medicaid funded. They're not consistently available. They're not easy to access. Some of them are grant funded or supported through some other means. And so what we're proposing here is that these be Medicaid reimbursable services for kids that meet medical necessity criteria. And the hope is that this broader array of services will take a lot of pressure off some of our existing services, for example, clinic. So those of you that work in clinics know that as sort of the general entry point for kids and families in mental health care, you really get inundated, right, with a lot of needs that sometimes you can meet well and sometimes you can't. And our belief is that things like mobile crisis, things like peer support will help ease some of that pressure that's on our existing programs. CPST, Community Psychiatric Supports and Treatment, provides a unique opportunity to appropriately reimburse providers for things like sort of proprietary models of evidence-based treatment, things like functional family therapy or multi-systemic therapy. That's rather exciting because those of you who have delivered those types of models or know of them know that they're expensive. They're expensive to get the training. They're expensive to deliver. They don't fit neatly into our clinic billing structure. So there's not a lot of those models out there, but they're highly effective. And so we're pretty excited about CPST and the prospect of making some wider availability of evidence-based treatments out there. So there's a lot of words on this slide, but this is the proposed home and community-based services array. So what we've done here is we've taken the existing services from those waivers that I mentioned earlier. So OMH operates the waiver, OCFS actually has 3 waivers in one, and Department of Health has the care at home waivers. And so we took a look at all those services, and we've sort of squished them all together to one service array. And so the concept here is to break down some of those systemic silos or barriers, if you will, that have occasionally made it hard for kids to access these services because they don't fit into one of those categories or eligibility categories. So we know that these services work. We believe that more kids should have access to them, and we believe that if more kids do have access to them, they'll be prevented from needing higher levels of care. So let's talk a little bit about a couple of terms that you may have been hearing been thrown around recently, and I was saying them myself a minute ago. So the slide that we just saw with those home and community-based services, so what we're proposing in the Medicaid managed care model is that more kids will have access to those services. And this is how we're going to do it. So in the current environment, with our current waivers, in order to access those services, kids need to meet something called level of care criteria. And all that means is that those kids have to be at imminent risk of institutional placement, right, out-of-home placement, either in a hospital or a nursing home if they're medically fragile, or a residential program. And that's good that those kids that are at immediate risk have access to those services. But we at OMH, we've long recognized that there's a gap, there's a service gap. So when kids are in, for example, the OMH home and community-based waiver, they're getting a range of services, they're getting a lot of those services, and what can happen is that they do very well and they're discharged, and then some of them cycle back because all that's available to them once they are discharged from the waiver are the state plan services, like, you know, clinic, day treatment, et cetera, and those are very good services, but sometimes they're not enough, right, because they're not those, they're treatment services, they're clinical services, but they don't have those support services, for example, respite or intensive in-home or the family support. And children and families sometimes experience a deterioration, even though there had been improvement. When those services are removed, there's a deterioration in functioning again. So we've long recognized that there's this big service gap, and we haven't until now had a real meaningful opportunity to do something to fill that gap. So when we transition to managed care, there's a mechanism that we can use to allow kids that meet what we call level of need to access those same home and community-based services. So what does level of need mean? Well, it means that they're not at imminent risk of being placed at home, but they do have functional deficits. And they do demonstrate need. And so what we're proposing is that kids that are either stepped down from level of care, or they step down from inpatient, or they step down from residential, be able to access this array of home and community-based services at a lower level of intensity, a lower level of frequency, but they're the same services. And that's a pretty intriguing possibility that you know, we're pretty excited about and are advocating strongly for. So, so what started out as really strictly a children's behavioral health transition into Medicaid managed care has broadened a bit, and you see that reflected in this eligibility criteria. So children who, for example, have been impacted by trauma, right? Used to where it says here physical, emotional, or sexual abuse, neglect, or maltreatment. That's trauma. And so we're looking to broaden the kids who are eligible for these services. Why? Because of all the things we talked about at the beginning of the presentation, right? All those kids that sort of go unrecognized and untreated. Those are these kids, and they do have to. That just because they've have a diagnosis or have an impact alone is not enough. They have to have an impairment in their functioning as a result. And so a lot of you hopefully are familiar with the CANS New York. So, as we've been discussing, children's presentation along the behavioral health continuum is rather fluid and varies over time. A child might enter the system by accessing the emergency room and then as a result might be referred to inpatient. That same child might then have a discharge plan and access home and community-based services because they meet level of care. And as they stabilize and the family is afforded the supports that they need, they might still need the home and community-based services, but in a decreased intensity. So they're moving to that level of need that I was talking about. So how are we going to track all that change in functioning? It's going to be with the CANS. So we'll determine children's functioning by completing the CANS tool. And many of you know that tool was developed by Dr. John Lyons, and it's used widely across the state as well as many other states across the country. And we're going to be working with John to develop an algorithm score that will determine kids' acuity level for access to services. So, so here's sort of what our current continuum of care looks like, right? And I have to thank Lydia of the Speed Tech crew. She worked really hard to animate this slide for me, and it looked really pretty, but we couldn't get it to work. We couldn't get it to work with WebEx, so not anybody's fault, but it looked really cool. So maybe someday we'll be able to show that to you. But so imagine these sort of things kind of popping up in sequence. But this is our continuum, right? It's kind of linear. We do have, we're happy to say we have some family support, for kind of on the lower end that catch some kids and families, We do, there's been a widening or broadening recognition, or growing really recognition that of the role that primary care physicians play in addressing kids' social and emotional development challenges, and because we know that more often than not, parents bring their kids to the pediatrician when they're concerned, right, about behavior or about development. So, and we've been working in a couple of different ways with primary care to strengthen their approach to these kids. We have something called Project Teach, where we provide training and consultation and help with referrals. We have some co-located clinics throughout the state, so we do a little bit there. And we have our clinics, school-based and community-based, and we've got day treatment, and then we've got our higher-end services, right, waiver and residential and inpatient. And it's a pretty good system, but it has some gaps, right, like we've been talking about. So now I do need to point out that this slide was supposed to have been animated too. So it's with great disappointment that I tell you that the animation on this slide doesn't work. You know, it was absolutely lovely. When it does work, it looks great. So if you can imagine this pyramid sort of growing. So on the base, remember earlier I showed you that it's more like a cone, but it was like this pyramid type thing, right? Where on the base you have these sort of more basic entry level kind of things going on, right? So on the base of our triangle here, and this is how we'd like our system to sort of evolve, right? From that line to this pyramid. So the focus really is on bolstering, right, the lower level services to prevent the need for more restrictive settings. And you'll see as we go up the triangle, home and community-based services are really key. For example, before referring a child to day treatment, we could surround the child with a blend of clinical services as well as home and community-based support services. there's a lot to what this is. This is really sort of the pictorial for our vision of where this design is going, right? So you have true integrated care here. You're working with primary care to better identify kids, identify them sooner, hopefully screen them. We do a little bit of that. We're hoping to be able to do more. We have, as I mentioned, the co-located clinics and Project Teach. And then you have, so there's more, as you go up the triangle, there's more intensity of needs, right? So then you can add support and advocacy. And at OMH, we highly, highly value peers, both family peers and youth peers, and what they can contribute to kids and families in the wisdom that comes with their lived experience. And then as we continue to move up here in intensity, there's community support. And here are some of the new services, right? So mobile crisis, the CPST that I talked about, psychosocial rehab. And then continuing to move up, more clinical services. These are more treatment services, right? Our clinics, our existing clinics, other licensed practitioners that are able to deliver therapeutic services, clinical services. And then we have our HCBS services. That's just 3 examples. That's not all of them, but that's all we could fit on the triangle. But there's lots more, right, that we saw on the slide earlier. And then finally, up at the top, this is the most intensive. And so this is our, inpatient, day treatment, residential. And so the hope is that if we build this right, that it will become less likely that kids will sort of escalate up this, ladder, if you will, or this grow in their intensity of need, that rather we'll catch them with all of these services, kind of filling those gaps that exist in our current system. And so I love that picture. The goal is to get kids back on their developmental track, right? Identify needs early. I know I sound like a broken record. Maintain the child at home with services and supports, and keep the child in the community, which is the idea is to keep kids in the least restrictive setting. So just a few words about what our next steps are in the managed care design. This is only 5 bullets, but if you could imagine, there's about 25 bullets, sub-bullets under each one. So there's lots and lots of work left to do on this design, but we're continuing to plug away. And so it's really my hope that we can continue this discussion about how together we can create a reimagined children's services system, one that's much more comprehensive and complete than the one that we have now. So let's talk a little bit then about what you as providers need to be doing to gear up for all these changes. And we do have the gift of time, although it doesn't feel like a whole lot of time. And time seems to be rapidly slipping away. But we do have some time to do some assessment and some planning. And so that's why we wanted to do this series of webinars now, rather than, a year from now when the change is really upon us. And just to plant some seeds of some things that you can be considering now, that really, centers on understanding who you currently serve, developing an agency-wide profile. These are sort of things that we don't, we sort of inherently know, but we don't spend a lot of time thinking about or writing down anywhere. But I think now is a good time to start really profiling your populations. Think about what insurance plans your clients are enrolled with. So some of you are already dealing with managed care, and particularly if you're, of course, in a clinic or in an inpatient setting. But some of you are not at all dealing with payers, insurance companies. So you might want to think about, you know, how are your clients covered? What are the plans that they're associated with? You might want to map out the services that you provide now, and really think about what services you provide to whom. And then also think about if you're already providing home and community-based services, or if you're not, are you associated at all with an agency that does provide those services? Because I think you've been hearing me say those services are really going to be critical as we move forward in this new design. Oh, so it's time for another poll. So this question is, are you currently providing any home or community-based services? And your choices are yes, we provide them directly. We partner with other agencies to provide these services. No, we don't provide them at all, or we're not sure.
Great, thank you, Donna. So the poll should have popped up on the right-hand side. Please make sure to click your response. Yes, we provide them directly. We partner with other agencies to provide them. No, we do not provide them at all currently, or not sure. And in just a few seconds, we'll close out that poll and see the results.
Well, I don't want to do it yet.
So, Amanda, once we have enough, we can close the poll, and the results should pop up momentarily.
Okay, so, all right. So there's some that do, a few that partner, a few that don't at all. Uh-oh, there's some of you that aren't answering. Okay, but it looks like there are a number of you that do provide the services directly. Good. So you know, well, I don't want to spoil any surprises, but we will be talking in future webinars we'll be talking more in depth about specific services, so we'll get more into that in the future. But so I guess with all the change that we've been discussing today, I just think it's maybe appropriate or comforting to, you know, to just remind ourselves and reassure ourselves that there are some constants here, that the basics of good care are not going away, right? Like we're still going to abide by the, you know, the CASP principles and the system of care principles. We're going to, you know, believe in truly engaging youth and families. We're going to give youth and families a real voice in treatment. We're going to continue to do those things. We're going to continue to use evidence-based practice and hopefully even grow that. We're going to continue good cross-systems planning, and we'll say a few more words about that in a minute. And we're going to all continue to have hope because, you know, one of the, I remember being struck by some research once that said that if that a therapist having the hope and the belief that a client can and will change is one of the most reliable predictors of therapeutic success. So we all have to continue to have that hope. And so just a word about cross-systems collaboration. You guys already know this. I hope I've been making that point sort of throughout the presentation, but we do have, and now more than ever, we have to continue to to work with our partners, our cross-systems partners in meaningful ways. And I know there's lots of really good work going on with, you know, system of care and other cross-system planning groups, you know, throughout the state. And I just wanted to make the point that that now more than ever is important to keep that going. So I'm going to leave you with a joke. So we've just started to talk today about how to use the opportunities before us in order to reimagine children's mental health services. The next steps require innovation on your part as providers. So here, for those, in case you can't read it or you can't see it, so there's two guys sitting. One guy's behind a desk and he's reviewing a piece of paper, and he's saying, "This really is an innovative approach, but I'm afraid we can't consider it. It's never been done before," which, you know, is silly because, of course, that's what innovation is. It's never been done before. But my hope is that sort of the naysayers in all of our collective organizations don't inhibit our capacity to think out of the box during this time of dramatic change, change that really will require us all to innovate. And I especially hope that the guy sitting behind the desk saying no is like not a guy who works for OMH, because I think frankly we've been guilty of that kind of squishing of innovation. And so if anybody out there listening ever feels that from me or, you know, anybody else, I would want to hear that from you. But let's all feel free to sort of be innovative and think really outside the box here. So with that, I'm going to turn it back over to my friend Mary McKay.
Thank you. Well, Donna, thank you very much for that presentation and for trying to convey very complex information that in some ways is still very much in flux in New York State in a way that's clear and also has children and families at the center. So I really appreciate you kicking off this webinar series. So I guess there's a couple of things comments that I would make in response to your presentation, and then thankfully you really did leave some time for questions, and I know you and your team in Albany are trying to monitor the chat box and identifying a set of questions that maybe you can answer some of them now on the webinar, but as I see them kind of really rolling in, we'll also probably want to organize some of those questions and have you respond, you know, thoughtfully on the CTEC website. So as you were talking, I in some ways reflected on the journey that we have been on in the Children's Technical Assistance Center. You know, we are in some ways, you know, still relatively new. You know, just a little bit, 3+ years ago, you and your colleagues really wanted to make an investment in providing support to children's clinics. And over the course of this journey, it's become really clear that there's a lot of overlap between children's services and agencies that also serve adults, and so we've tried to expand our scope of work to refer to ourselves as the Community Technical Assistance Center, that we really want to support the public system and agencies to remain vibrant. But as I look at the way you've outlined the children's service system, it's really clear that it won't just be clinics that are going to be affected by this transformation. It's going to be the whole continuum of services, from family support services to the community-based services all the way to residential services. And so what I appreciate about you and our partnership with OMH is that CTAC is going to be able to expand some of those support services, because we're going to need to move beyond clinics and think about supporting both vibrant existing parts of our current system, but also filling in the gaps with the services and the supports that are not there. And so over time, we're really going to try to think with you very quickly about what kind of other ways we can provide support to different parts of the children's service system, and I really appreciate that support of CTEC. I'm also really aware that although there are parts of that triangle that you put up or the pyramid that you put up that are kind of the cornerstones of the children's services, we have a lot of work to do there. And so I'm thinking hard about, you know, how do we fill in some of those cornerstones that might be so important on your pyramid, but maybe not be as vibrant as they're going to need to be to help prevent the movement up to high-end services for kids. And so I think that's important when you put up the slide around what are we going to need to start doing. I think community-based work, I've come away that our ability to move seamlessly from communities to clinics and back again is going to be really, really important. Our ability to partner with primary care and family support services, that even in a system as vibrant as New York State, we can have quite a bit of silos. I think that those are going to be important, and I certainly want you to consider CTEC as your partner to kind of help us all think about how to do that work better. I'm really also aware that we've scratched the surface in terms of what we are going to have to learn, relearn, unlearn, and so I'm grateful that this is the first in the series for us to have some conversation around what are the core competencies that are going to be needed by which parts of the workforce. You know, where do we do a good job already, but where do we need to work to improve what we did, what we're doing. You reminded us and encouraged us to study ourselves. And so I think I want to pull that also out of your remarks, because I think our ability to use data as children's providers across the continuum to be able to be very specific about who we serve, how we serve them. I did have some questions around, you know, to what extent are we going to need to articulate our outcomes, how clearly, how much we are going to be able to identify the ones that matter most for kids and families, to what extent are we going to have to align with the standard set of outcomes. I think that that might be a topic that we might want to cover going forward, and certainly a set of our core competencies that we're going to have to build in children's services. And so I think that that might be another area where CTEC should kind of think about, you know, really helping our systems improve in our use of data and outcome measurement. The slide that everybody is looking at right now has two additional dates, December 17th, which is Gearing Up for Change, and January 14th, Understanding the New Menu of Services. We recognize that the children's menu might be a bit more added to or changed, but I think that based on the information that we have now, it is very wise for us to start to plan and think through how we would align what we currently do or what would be needed to really be able to meet the state's hopes and priorities for a reimagined children's system. So know, Donna, that CTEC is really happy to partner with you and those of you on the phone, the provider organizations, the family organizations, to really see if together we can understand how to use these new opportunities to really help children and their families get better care and certainly, you know, help them to improve their lives. So I don't want to talk too much longer except to say thank you and then to move into some questions and answers. And again, as I look at the chat box, it's really been quite active. So if you want to try to peel off a couple of the questions, Donna, that you see and answer those. And then again, CTEC community, we will try to do a good job kind of chronicling the other questions and providing some answers on our website. But Donna, I'll turn it back over to you.
Thank you, Mary. All right, so there are a few questions I can pull off here pretty quickly. So someone had asked, where does OPWDD fit into all of this? And so the answer to that is OPWDD has taken their own approach to managed care for kids who are eligible for their services, and that's through the DISCOs. We have had some discussion with OPW in terms of, any overlap, particularly in terms of kids who don't meet their eligibility but do meet ours, but nonetheless have some form of developmental disability. So there are those discussions happening. But in terms of the managed care design, OPW is doing their own model. There was another question about, in regard to our model, which, if I could find it quickly, the model visual, and are the children's clinics. Oh, I'm not sure I'm going to be able to find it. The question was, are the children's clinics included in the blue circles in the model? And they are. And I want to
Don, I think the question was, are Article 31 clinics included under behavioral health provider in the model?
Yes, and the answer to that is yes. Thank you, Lydia. That's correct. So just to reiterate, so Article 31 clinics would be in this one of the blue circles here that reflects who the managed care organizations would be contracting with. Mary talked a little bit about measuring outcomes. There were questions about, can we know more about what outcomes will be measured? Is it going to be the state or the MCOs that dictate what those outcomes are? And the answer to that is a little bit complicated, and we're not 100% there yet, but there are some standard measures that will be applied, and we're working with the Department of Health to develop additional measures and outcome measures that we will keep you abreast of that once they're developed, but they're just in process now. And Mary's absolutely correct that CTAC will be well positioned to work with you guys to understand how those measures relate to any outcomes that you're already collecting, any data that you're already collecting, any outcomes that you're already measuring on, and they'll be really, CTAC will be such a valuable tool for you to keep up with those developments as they become available.
And Don, I can just add that thanks to your support and then also the support from the New York State Health Foundation, we have been organizing and compiling, the open source, low burden, kind of standard set of outcome measures that I think could be incredibly useful for provider organizations across kids clinics, kids services as well as adults. We'll have a portal where you also can benchmark yourself against a set of standards if you're in a part of children's services, different parts of children's services, and so that will be something that'll be coming providers' way over the next year. And so we definitely want to make sure that we put in your hands as easy to use tools and some real capacity that will bolster the capacity that the organizations have. Yeah. Don, I also see a question around peer training, and I know you mentioned that kind of youth support, family support was going to be important, but did you want to make any comments around, some of your thoughts around those portions of the pyramid?
Sure. So this is another area where OMH is partnering with CTAC and their sister organizations, including most prominently Families Together of New York State. Hopefully, many of you are familiar with the existing family peer credential that Families Together of New York State has organized and is providing for currently. So there's going to be continued effort to train and credential family peers. You probably know that the youth peer movement is not as far along as the family peer movement in terms of, sort of organizational structure, but we are continuing to support Youth Power in their efforts to secure more training and more support for their youth peers that are gradually growing, and their growing presence in the community. So we'll be continuing to develop that. A lot of what's going to be entailed in the early stages of the managed care transition is capacity growing sort of across the board. And so family and youth peer will certainly be a focus for us to provide whatever supports we can to grow capacity in those areas.
So I know, Donna, you're taking a look at the chat box. There were a couple of concrete questions that you might or might not know the answer to. One was about SPOA and what role it might play within the kind of newly configured, kind of children's service system. Is there discussion about that, or is that in process?
Yep. So there's lots of discussion about that currently, and SPOA and the role of the local governmental unit. So we haven't landed on that one yet. There's lots of discussion and planning with representatives from not just mental health county government, but also social services and health, local departments of health. So, back to my point earlier about this being really a cross-systems approach, and when we talk about SPOA, that's the mental health entry point. And so we've started to broaden that discussion to not only SPOA, including SPOA, but also including these other local governmental agencies that have a role to play in terms of determining eligibility and determining access to services. So kind of more to come on that one. So let's see, I see a question here about, I just lost it, something about the HCBS manual. So this question is, I'm familiar with the adult HCBS manual recently released. Where do I find the children HCBS? So that doesn't yet exist. I think there's been some, when the adult manual was released, maybe there was some confusion that I was just noticing in my email this morning. So, so we want to note that the manual that was just released is in regard to adult services only, and that we're not anywhere near on the children's side we're not nearly ready to release a manual. You will be hearing from us in plenty of time to get ready to look for that, but not anytime soon.
So Donna, I know that you covered this question, but I think it's worth just maybe hearing your thoughts again, because there's a lot of information to take in. So we currently in New York State do have a set of waiver services, home and community intensive home and community-based services, and yet this new bottom of the pyramid that's also called home and community-based services, they are the same or they are different. And I know that not all the details are worked out, but are there some distinctions that we should be making, in some ways that we should be preparing ourselves for a whole range of home and community-based services? Is that too hard a question?
No, it's a good question. So, I wanted to pull up the triangle so we could look at it together. So, so the home and community-based services specifically that we've been talking about are really existing services. I think there was a couple that were new that we kind of added, but for the most part, they are already in existence between or among the 6 existing waivers that are currently operating. So, how did that happen? Okay, if people want to look at this, so these are services that are out there already for the most part. And there are providers, either some that are on the phone listening, and some that maybe are serving more of the medically fragile population or the DD foster care population, for example. But a lot of you guys are already familiar with many of these services. And so we're not talking about qualitatively changing any of these that are already in existence. We're really just talking about adding to them, making this a continuous array of services, and making these services more available to children who don't necessarily sort of fit neatly into those, you know, systemic silos that currently access those services. So these we're just building upon something that already exists. We're not looking to change these services or to alter them. We're looking to make them more accessible. We're looking to make them more widely available. We're looking to make them more flexible in terms of the amount or the frequency in which they're delivered to kids and families. Does that make sense, Mary?
It does. And and then also, I expect that there'll be some kind of application process that if currently you don't provide these services, that you'll make to be eligible to provide these along with what you typically provide. Is that correct?
Yeah, so I'm going to give you a little bit of a qualified answer. I mean, we're a little bit too early in the process to really answer that firmly, but you guys will be the first ones to know once we've got it set in stone. And that's really that's really about you know, getting approvals from the CMS.
And you know what, I just want to underline that what I really appreciate about what you're doing right now in this dialogue in the webinar is there are a lot of things still in flux, but you're willing to communicate about them. You're willing to help us kind of, you know, think ahead without having every definitive answer. And so, I think that you know, I think there's probably many of us that really appreciate that dialogue, as opposed to just wait until everything is all tied up and then it gets presented. And it gives us less time to kind of think and prepare. And so I really, qualified answers are actually, you know, real leadership and really appreciated, I think, Donna, by us. So Donna, it looks like we are almost at the end of our time. Any final word that you want to say? And then I will definitely say once more thank you to you and others for being here.
Thanks, Mary. I just want to thank everybody for their attention. I know everybody's so busy. I have a room full of my staff and other people's staff here, and I want to thank them for hanging in there with me. I want to thank all of you for your, you know, your interest and your commitment to children's services. I'm sorry we can't get to more of the questions, but as Mary said, we'll go through them and answer them in detail and post them for you. But I do look forward to, you know, ongoing conversation with you as we move forward. And I think this is the most important work that we could all be focused on right now. And I just appreciate the opportunity to work with you all on it.
Great. Well, Donna, thank you so much. So just an answer to the question that just came in, the slides and the full recording of this presentation will be posted over the next several days on the CTAC website. There's some additional resources that you see up on your screen around the MRT, around the DOH Health Home website, and certainly CTAC will be also a website that this recording, the slides, and other resources will be put up. We appreciate also this next slide around questions about children's managed care, as well as CTAC questions can be directed to these individuals, Angela Keller, Lydia Franco, and again, we'll post the recording, the slides, and additional information as it becomes available on the CTAC website. So with that, thank you so much. Have a very good afternoon and a very good weekend. Thank you all.
Thanks, Mary.